Okay, greetings everybody. We're going to get started on this lecture today, and this is part one of a two-part series. This is Understanding Pain. And to start off, I want to give a little bit of background about who I am. So I am Dr. Kevin Cuccaro. I was trained as an anesthesiologist at the University of Chicago, great institution. Anesthesiologists are a little bit different than most other physicians because we have a tendency to work more with other docs while we're taking care of patients. And we're primarily in the operating room. We deal with surgeons. We're also on working with obstetricians and delivering babies, providing epidurals, and involved with cesarean sections and things. But I'm also fellowship trained in pain. Okay, and I was trained at the University of Michigan, and pain medicine is an interesting field. As a fellowship, it only has been around for about the last 20 years. Looking at a lot of needle injections and things and trying to understand pains. But what I really like about the University of Michigan was it really taught us to focus on outcomes. What is it we're treating and what is it that we're hoping to achieve? Then after my medical training, I practiced in the military as an active duty military physician. That was a great experience because I practiced with 6 other fellowship trained pain physicians. So these were all physicians who had extra training and were certified in pain. I was in San Diego at the time. We had a large population of patients that we saw. We're in the middle of the war on terror. So we had blast injuries, multiple different types of trauma injuries, people coming back from Iraq and Afghanistan, and a very broad mix of pain patients. Okay, we also had some people who had chronic pain from not being in war zones, and there was some very interesting things that we saw. In fact, I could see somebody, and I've told patients this, with literally 3 limbs blown off their body using almost no pain medication at all. And I've seen people who were never even in a war zone, young guys who look perfect, who would complain of horrible back pain. So at that point, there's this disconnect between what pain is and what we were treating. And I also wasn't very satisfied with what our outcomes. Okay, we tried to do the best we could, worked really hard, but I was not satisfied. So satisfaction for me is I want people to see a doctor. I want them to come in, and I want them to get treated or understand things or feel better, so that they don't come back to the doctor again and again and again. To me, really a successful interaction is one where the patient is doing well enough that they no longer need you. And we tried to do this in the military. It was a little bit harder with the follow-up and things. And to be frank, I thought I was, I had a little bit of arrogance there. I was assuming that if I was seeing the patients, I was, deciding who would get the procedures done, if I could just categorize them and then I could follow them up aggressively, that my outcomes would be different. Because when I was in the military, we would follow a patient. I may see somebody else may do the procedure on them. They may follow up with somebody else. So it was a little bit chaotic on that end. So when I left the military, what I really was looking for was an environment where I would see the patients, I would do the procedures on them because I was trained in these procedures, highly trained in these procedures, and then I was convinced that if I was seeing them, I was doing the procedure and I was following up, that my outcomes, meaning patients would get significantly better to the point where they were not using medications, they were off living their life, and not really seeing a doctor over and over and over again for their pain. I thought that would be different. And what I discovered was it didn't. Even though I was now by myself and I was such a hotshot, patients were still having the similar outcomes, meaning they kept coming back again with pains over and over and over again. And this was a little bit disheartening to me. All this training, all these things that I had done. And in 2012, I started doing some kind of revamping and returning to the roots and going, really, what is it we're doing? What was I trained in? What exactly are we trying to achieve? What are the outcomes? And I started looking not only at the research that was coming out of interventional pain, meaning the people who are doing the procedures, but I started looking at the whole aspect of pain at different, different studies, different groups, from psychology to spine surgery to imaging and all these things. And it really started opening my eyes. Okay. So what is pain? And this is really the most important part of this lecture, is really understanding what is pain. Because we toss this term around quite a bit. I see it on news articles. I see it even in research studies that are coming out. And if you understand this definition well, it's going to change your perception of what pain is, and it's going to make you understand when those new, whatever magic bullet cures come out on either through email or through ads and advertising. You're going to be going, you know what? That doesn't seem that's what pain that they're talking about. So what is pain? Well, if you look at the actual definition for it, People quote this quite a bit, that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms thereof. And really, if we kind of take out the medical gobbledygook associated with this, what we find then is that pain is an unpleasant, okay, has to be unpleasant, sensory and emotional experience. So those three things right there, sensory and emotional experience. Okay. Now, what pain isn't, it's not something that's called nociception. Okay, nociception, and we focus on these little nerves out in our fingers and in our skin, and what those are is really just a stimulus and a signal. So if you poke your finger, say with a thorn or something, there's little receptors and little nerves in your skin that say, there's something here. Let's send this up to the brain so that we figure out what's going on. So there's a signal that's generated from something that's stimulus, and this could be anything. This could be a thorn poking you. This can be a touch, someone touching you. This can be something getting hot. This is something being cold. But there's some sort of stimulus and signal that is transferred to your brain. Okay, so nociception is just a signal, little spark that goes up. And it is purely objective. And what that means is we can measure this. We can measure these nerves that are firing and going to your brain even if your brain is under anesthesia. So in general anesthesia, we put your brain to sleep, and if the brain is not be able to receive these things, there are still these signals from your body, and that is nociception, completely objective. And the way to kind of think about that is if you're, if you have a TV and it's plugged into the wall, there's still an electrical current that can go to your TV, but if the TV screen is turned off, there's no picture on it. Okay, so nociception is sort of like the electric current that can go through that wire. All right. Now, pain, however, is different then. Pain is a process. It is a signal and the meaning to that signal. So remember, pain is a sensory and emotional experience. So nociception provides the signal, and then the brain takes that signal and assigns a meaning to it. And because of this, pain is entirely produced in the brain. Now, you may feel things in your foot. You may stub your toe, and your toe may feel like it's hurting. But all of those sensations, all that's generated, that is created, is in your brain. Your brain is the place where that is developed, okay? And as such, this means it is completely subjective. So if we look at pain as compared to nociception, remember nociception being that signal, for pain, we can take away all pain. The way we do it is we turn your brain off. And we do that when we put people under general anesthesia. When we put people to sleep for anesthesia, you no longer have an awake brain. With a brain that is no longer awake, it cannot receive the signal from the body, when the surgeon's cutting you or poking you or whatever the case may be. And because of that, it cannot create pain. All right. Now, I'm going to touch on emotional theory here because this is pretty important, because remember, pain is a sensory and emotional experience. And if there's any psychologists reading this or people who've got a psychological background, I'm going to take a very complex field. I'm going to condense it in about 2 slides here. Okay, so this is really for understanding. There's a whole bunch more to talk about here, but this is a good starting point. All right, so if you look sort of emotional theory, there's this traditional view that about 40 or 50 years ago or longer, that emotions are less mature than reason. Okay, that we're rational beings. Emotions are that dark kind of undercurrent that's kind of stirring underneath everything, and that negative emotions, feeling bad or mad or sad, are really not good. And we need to rationally control them. So if you can just consciously say, I'm going to think happy thoughts, or I'm just going to squish down these feelings, that was a good way to go. Now, over the years, though, we've realized that actually emotions are very, very important, that they kind of increase our awareness of things. They make sure that we, what is important to us, we notice it more, and they really guide and motivate our behavior. Okay, so we like to think that we choose things for ourselves, but so much of our actions are unconscious and guided by the subtle emotional background that we have. It's very impressive. And so once we start talking about, we understand that these emotions are, even the bad ones, even the sad and mad and bad feelings that we get, they're very important for determining our behavior. Okay. Now, interestingly, Star Trek recognizes this. So if you guys are geeks like me, you look at that picture on the right side of your screen, or left side, whatever the way that you're looking at it, that's Spock. So the traditional view of emotion, Spock was a Vulcan. What are the Vulcans were? They were a race that repressed their emotions. They smashed them down. They only wanted to think logical thoughts, meaning only use reason. And this sounded like a very good idea. Now, by the time the next generation, which is on the right side of the screen, the progressive view of emotional theory, they realized that having someone who could only think rationally and didn't have any feelings or didn't want to express their feelings was about the worst thing that you can do on an interstellar starship. Because when you're approaching an alien race that you may have never encountered before, okay, they may process information, they may respond much differently than you. And unless you can understand the feelings that are really underneath the behaviors that they have, you are going to have some bad interactions, interstellar wars and blowing up and who knows what else happened with their phasers and things. And so they realized by the time the next generation came around that you needed an empath. And that's Deanna Troi. And she was an empath, so she could feel what people were feeling, and she could understand the emotional needs that they were having. And that is much better, because if you have even an alien, we encounter an alien that we think looks like us, maybe look completely humanoid, and they may approach us smiling with open arms, and a rational being, we'd say, wow, that looks like they're doing friendly behavior. But if we don't recognize that emotionally that person may be terrified, and in that particular culture, smiling with open arms means I hate you and I want to kill you because you're frightening to me, you can see where that's going to end up. So you really want to understand feelings. Feelings drive behavior. Very, very important. And again, if you're out in interstellar space, you really want somebody who can feel things rather than someone who can think things. All right, the other part about this is what we call emotional states and processing. When you look at this iceberg here, emotional state is really the top of that iceberg. It's that little small part that's really in the conscious mind, and that is where we are now, the feelings that we are right now, happy, mad, sad, or glad. But underneath that iceberg, all underneath that ocean, is the emotional process that brought us to that state. So if you sort of imagine that these thoughts and feelings that we have to come up through the ocean, along all the way through all that iceberg underneath that water level before it reaches the conscious mind, we can see that emotional process, how we got to where we are, happy, mad, sad, or glad, is incredibly important and is a huge portion of how we're feeling. So again, emotional state, where we are, happy, mad, sad, or glad, emotional process, how we got to that state. Okay, now neurobiology of pain here, and I'm going to make this brief and shouldn't be too confusing. If there are any questions, let me know. Neurobiology of pain was first described as a 3 dimensions of pain by Melzack and Casey, a couple of famous scientists, in 1968. This is one of the later pain theories, but it really seemed to describe and go with pain quite well. And what they said is there's 3 dimensions of pain. There's a sensory discriminative branch. This is really where the pain is or where that signal is coming from. There's an affective motivational branch. This is describing what does that signal mean. And then lastly, the cognitive evaluative branch, which is really telling us how should we respond to that. So sensory discriminative, telling us where that signal, where that nociceptive input is. Remember, that unpleasant sensation may be. The affective motivational branch is telling us what does it mean, right? And then lastly, the cognitive evaluative is what is that, or what is our response to that. And interestingly, we're sort of wired for this. So if you actually look at our bodies and where the nerves lie, we have what's called a lateral pain system and a medial pain system. And the lateral pain system is predominantly the sensory discriminative branch. It provides the location of the stimulus. If you poke your finger, it tells you that's where you're feeling that poke. The timing that you just got poked now or it was yesterday. And the characteristics is it's sharp, dull, burning, aching, and things. And this prompts withdrawal, prompts these reflexes that we have. Now the medial pain system, though, this affective motivational branch provides the emotional coloration. As I said, it's telling us what does that pain mean, and really is around organizing defensive behaviors. Okay, so if you get poked with something and you happen to just, you touched a branch and you're trying to get some fruit off of it, and it stabbed you with one of those little needles there, your affective motivation branch is going to say, ow! You can have that withdrawal initially, that reflex that we really don't control, and then you're going to say, wow, that was kind of sharp when I was trying to reach for this thing, so next time I'm going to be more cautious about going through that plant and being careful of those thorns. All right? Now, another way to think about this is a microphone, a mixer, and a speaker system. Okay, and really the sensory discriminative branch is just the microphone. It's the input into the system, meaning that is just the signal. The affective motivational branch is that mixer, which is that large box there with all those knobs and things. And then the cognitive evaluative branch is kind of like the headphones or the speakers, where the output of that noise is. And as you can see is that input, that thing from the mic, you can scream into the mic, you can talk softly in the mic, but the way you change that mixture, you turn the dials up or down, really influences what the sound is, what the experience is that's going to come out of that. So really, what is pain then? Pain is an unpleasant sensory and emotional experience. Okay? 3 things there. Sensory and emotional experience. Nociception only provides the signal. So if you're poking your finger, burning your hand, stubbing your toe, those little nerve fibers, those little peripheral nerves, only provide the signal. Okay? They are not pain. Right? They're just a little electrical spark. The emotions, however, our emotions, change our awareness and guide behavior. They can amplify that information. They can change the way we respond to that information. If we stub our toe versus poke our toe versus, get a sunburn versus get burned by hot oil. And then we have to remember about emotional state and emotional process. So where we are right now, happy, mad, sad, or glad, is going to heavily influence our pain experience, as well as all that underpinning, that process, how we became happy, mad, sad, or glad. All of the experiences, all of the events that led us to where we are right at this moment, or at that moment when you're experiencing pain. Now, what does this all mean? All right. What it tells us is that our pain experience, and really if you think about pain, if you're talking about I'm having pain or that is painful, you should be adding the word experience on it. Okay, it's not just a thing. It's a pain experience. It's something that is happening continuously. But pain experience and emotion are tightly interwoven and influence each other. So that emotional state, how we got to that emotional state, heavily influences our perception of pain. And that our experiences of pain can either be primed, meaning we can heighten them, or amplified by emotion. We can also diminish or decrease that experience of pain in similar ways as well. So that experience complex and it's influenced by past experience and trauma, the nature of the injury that we have. It's that if you poke your finger while you're going for a piece of fruit or you're harvesting, lemons or whatever from a lemon tree, they have big old thorns on them. That's going to be quite different as compared if someone pokes you with a needle. Someone's mad at you and they stab you with a pen or something. If you have gotten your back starts feeling sore because you just started a new exercise regimen and your body is sore, versus you were in a car accident and your body is sore from all the the tight muscles that you had at that time. Very different pain experience. Uncertainty and fear can influence us heavily. Okay, pain is scary when you're having pain. The worst worsening pain experiences, and you have something occurring, and often we see this with back pain, and people are terrified. What does this mean? What's my future going to be? All of those uncertainties and fear can increase our experience of pain. They can actually turn up the dial and make it hurt worse. Okay? Or if we're afraid that it's going to happen again, or afraid that it's never going to go away, that can actually influence pain as well. And then our beliefs about what that pain experience means, whether good beliefs or bad. So let's take about that workout example again. If you have a sore back because you've just been working out, most people are going to say, man, my back is sore, but I really got a good workout and it's going to get better over time, versus, man, my back is sore. That car accident, what does it mean? I must have something wrong with me. And what about the car insurance? And how am I going to pay for this? All these different beliefs. And the other ones we can talk about, which we will in a future talk here, is how we influence this in medicine. Okay, we are very good at propagating bad beliefs. This has to do with imaging and people looking at their back and saying, well, all your back pain must be because of a bulging disc. And just sort of giving a little foreshadowing here, that is not true. Okay, but we really are influencing people to think that they're crippled, or just because of the pictures that we get of your back and what we tell people. All right, so beliefs, good or bad, influence that pain experience. And pain is not either physical or emotional. Okay, there's no such thing as just physical pain or just emotional pain. The pain takes all. It's an experience that we have. It's all essentially, all produced in our brain. Okay, and it is really this sort of center point here between the stresses that we're having in our life, how we're wired. There is some genetic component to this stuff, sensitivities and things. How we think about the pain, that's cognition. How we feel about it, That's the emotional part. And then how we're responding. What is the behaviors that we do that influence this pain experience? So right in the center there of all of those things is where pain experience lies. Now, remember, nociception is not pain. It is only a signal. That signal requires this emotion. It requires this effective motivational branch to become pain. It only tells us where something may be located, and you have to have a whole separate host of other things that tell us what does that mean, all right, and so that we can decide how to respond for it. So I want people to recognize that, because when you see these things that says, oh, pain is now due to, we're discovering this particular pain is due to these little nerve fibers out in their skin, okay, no. That's nociception, not pain. All right, and when we start ignoring this, we try to simplify the pain experience to something that doesn't have this emotional component, that requires an awake brain, we start running into significant problems, which we'll talk about in a future talk. And also important to realize, though, that pain does not represent failure or weakness. Okay, it's just important to realize that your pain experience is wrapped up and influenced by these emotions. Okay. Lastly, I just want to touch on here whether, the central component of pain, which all pain is coming from the brain, is very important to realize. It has huge impacts on your health, which we'll touch on in the future. Now, if you have questions about this, comments, or just confused, visit straightshothealth.com, put a comment there. There'll be some other videos there as well. Or you can just email me directly at drkevin@straightshothealth.com for general pain questions. And I will try to get those as fact. Obviously, if you're having some sort of emergency, this is not the way to do it. This is for information. All right, folks, it was a pleasure talking to you, and I look forward to touching on these topics again. See you soon.